Good morning. This is Victoria Beal with the Ohio LTAP Center, and we are very pleased this morning to be able to present a webinar on one of the newest courses in our Active Transportation Academy. It is an overview of the Health, Inequity, and Transportation course, and the webinar this morning is going to be presented by Michael Blau of Vinton Planning. Michael, are you ready?
I am ready. Thanks, Victoria.
Great. And just a quick note before Michael does begin everything. If you have questions during the webinar, please feel free to put them in the lower left-hand conversation box. I will be happy to read those off to Michael. But we've also reserved about 15 minutes at the end of the hour for your questions, and we'll unmute the phone lines at that point in time so you can ask them directly if you'd like. So please feel free, though, during the presentation to put your questions in the bottom left-hand corner. And I am trying to record this webinar. If I'm successful, then I will send a link of the recording out to everyone. But if I'm not successful, it's a good thing you're all here. So there you go, Michael. Thank you.
Thanks again, Victoria, for facilitating this and organizing it. I'm really excited to share some of the material that we've been working on for the Academy in the past year. So this is a Health, Inequity, and Transportation webinar, and before we dive into it, there are a few housekeeping items that I would like to go over. Again, my name is Michael Blau. I'm a transportation planner at Vinton Planning Services and the program manager for the Active Transportation Academy at ODOT. In July, I'll be transitioning over to Tool Design Group. I'll still be teaching a lot of these courses over the next year or so, but I'll no longer be managing the Academy day to day. And just a disclaimer, as far as today's topics, I've had some experience in the public health field, especially around active living and neighborhood health programs, but I am by no means a health professional. I'm a transportation professional, and I'll be approaching today's presentation through that lens. Just want to make that clear since this is an interdisciplinary topic. I also want to acknowledge that, as you can see, I am a white male with all of the privilege that that entails, and I am discussing issues related to race and gender and discrimination and equity. If a woman or a person of color was presenting this, they would obviously have a different take on it and might have more insight, but I feel that as an ally, it's my job to talk about these issues and make people aware of them whenever possible and represent them as best I can. So we just did introductions. We'll go through a couple of Academy updates before we jump into the webinar, and then we'll talk about learning outcomes for the webinar and the in-person training. And then the training is divided into 4 parts. Part 1 is just a basic introduction to public health around concepts of health disparities. Part 2 will be looking at basic concepts around active transportation, including how active living can create healthy communities. Parts 3 and 4, we're not going to spend as much time on today. We go into more depth in these during the in-person training, but we will look at a couple of tools and resources and then talk about, at the end, strategies for building relationships and coalition building. So there have been some changes at the Academy in the past year. We transitioned from the Safe Routes Academy over to the Active Transportation Academy, since we're now offering a wider breadth of material related to all things active transportation. We're also expanding our media. We are developing an adult school crossing guard online training to supplement in-person trainings and in the field trainings. So that will be available later this summer. We are launching a new webinar series starting today. So hopefully, unless things go horribly wrong today, hopefully we'll have more of these in the near future. And then we're also developing new courses right now. We have 3 courses ready to go that are already being offered: community traffic calming programs, conducting walk and bike audits, and health inequity and transportation discourse. We're also going to be developing a few new courses which will be available later this summer. And then in the meantime, we're still offering all of the original Safe Routes to School courses as needed. If you want to apply for any of these courses, I encourage you to visit our application page down here, bit.ly/Active Transportation Academy, where you can apply online. And we ask that you have at least 15 people committing to attending the training. If you need help recruiting people or coordinating with nearby communities to do a combined training, we'd be happy to help assist with that. And of course, all these trainings are at no cost to you. They're all funded generously through ODOT. So I think that takes care of all of the housekeeping items. We'll get into today's webinar and today's topic, health and equity in transportation. Just a reminder that today's webinar is only a 45-minute preview of a 4-hour in-person training. So we're really just skimming the surface today. Some of the material I'll be sharing is just an introduction into much more in-depth topics. So if you're interested in learning more, again, I encourage you to request an in-person training. Today's learning outcomes. So first and foremost, we want to understand the causes, significance, and implications of health inequities and disparities. We'll be talking about the social and physical determinants of public health and their disproportionate impact on low-income and communities of color. We'll look a little bit at auto-oriented transportation networks and how they impact public health, how they contribute to the prevalence of chronic disease and environmental health issues. And then we'll be familiar at the end of this with some transportation-related health disparities and inequities. Number 2, we want to identify the intersection between public health and active transportation, explaining how active living and how active transportation can address health disparities and what types of best practices are being used in that field. Number 3, we'll be familiar with health and transportation policy analysis tools. Again, we won't delve into this as much today, but there are a lot of online tools that I'll show you that you can explore on your own. Number 4, possess practical knowledge of how to establish working relationships between public health and transportation professionals and underserved communities. So we'll be looking at communication strategies and other approaches to forging those cross-sector relationships. And then number 5, incorporating public health and equity considerations into transportation planning policies. Again, looking at how to actually implement this in your practice. Part 1, Public Health 101, Introducing Health Disparities. And just to clarify, I'm not sure if there are any public health professionals listening right now, but we're not talking about infectious disease or epidemiology or anything like that. We're just focusing specifically on the basic concepts around health disparities and health inequities. What is a health disparity? A difference in the incidence and prevalence of health conditions and health status between groups. These disparities can exist between groups for a variety of different community health measures. You could look at health status, access to health care, health risk behaviors, and these differences in health vary based on a number of reasons, primarily demographic, race, ethnicity, sex, neighborhood and other geography, income, education, sexual orientation, gender identity. There are many other factors, and oftentimes these factors can actually have greater impacts on health, on an individual's health, than genetics or access to care. So this might be a new concept for some of you listening out there. So to make it a little more concrete, I wanted to share an example with you. This is a story about a food desert in rural Ohio in Vinton County, which is in the southeast of Ohio. And I'm going to go ahead and play a short radio story for you all. And then as we're listening, I just want you to keep in mind a couple of reflection questions. What are some of the health disparities that may have resulted from the lack of a grocery store? And what are their causes? At first glance, it might not sound like the story has much to do with health disparities, but if you listen closely, I think you'll be able to hopefully connect the dots. So I'll go ahead and play the story now. I'm going to turn it up pretty high just to make sure everyone can hear it, so you may need to adjust your volume.
The only county in Ohio without a grocery store now has one. Even though it's filled with farm fields, Vinton County was without a grocery store for more than 3 years. But a local entrepreneur, with the help of government grants, has changed that.
Did you find everything you were looking for?
Wednesday, a rural food desert got its first grocery store in several years. The 12,000 square foot Campbell's Market opened its doors in MacArthur. The county's 13,000 residents are excited.
We haven't had a grocery store in 4 years. This is awesome.
Kelly and Greg Covery share the sentiments of every shopper I spoke with opening day. Now fresh produce is just a 2-minute drive from home.
just to be able to buy fresh stuff without having to go out of town. Because it takes like usually 30 minutes for us to go get something fresh to eat. So this is, yeah, great.
There were many inconveniences before Campbell's Market showed up.
The travel's one, gas money, the time, not having anything fresh when the kids want it. Strawberries, bananas, things like that.
The Healthy Foods for Ohio initiative provided about $1.6 million in state and local grants and loans to help build the store, according to market co-owner Rick Campbell.
Without that program, this project could not have happened.
According to the Census Bureau, over 20% of the county's residents live in poverty. The county's median income stands at $41,000, $10,000 below the state's median income. A small low-income population dissuaded commercial chains. The county's last grocery store, Super Value, closed in 2013.
We couldn't believe that there was no grocery store in this whole county.
That's where the public loan and grant package proved essential. Campbell's Market broke ground on the store in March and started construction in June.
The community need. We came down and investigated the area and talked to some of the community just on the street.
He says the store will make a big difference in the access residents have to nutritious food like fresh produce and cuts of meat. John McQuirt walks up and down the aisles, browsing the merchandise, checking the prices.
I usually go to Wellston or Jackson, and it's like 30 miles round trip. Sometimes it's not feasible, but you got to do what you got to do.
If the prices are comparable to Walmart, where McQuirt shops now, he'll switch over permanently.
Or if I need something in a hurry, yeah, it's convenient. It's right here. I live across the road.
Tony Williams and her husband guide their cart up an aisle. She does the cooking, and he does the shopping. Now he doesn't have to drive up to 40 minutes for a bag of potatoes.
Be glad to have, a place where we can come get potatoes and groceries and celery and carrots. And, Dollar General has some things, but it's not like a real grocery store.
The store was originally scheduled to welcome customers in August, but inspections delayed the opening. The store is overcoming the usual opening week issues. Trouble with a credit card processor meant people couldn't use EBT cards until around noon. But groceries are back in Vinton County. With day one in the books, residents and Campbell's Market's owner hope that the grocery store will be around for many more.
And we're just happy to get the doors open for them and us both.
Adora Namigate, WOSU News.
Okay, so hopefully you all could hear that okay. We're going to talk about the story now and try to situate that in a health and transportation context. So again, our reflection questions. What are some health disparities that may have resulted from the lack of a grocery store, and then what are their causes? Upon doing some research and thinking about this, the main disparity that I found is higher rates of chronic disease like diabetes and obesity in rural areas. As you can see on the map here, increased rates of chronic disease and death rates from chronic disease are higher in rural areas, especially in southeastern Ohio and the Appalachian counties. This map is from the Ohio Department of Health's report in 2015, the impact of chronic disease in Ohio. If you look at some of the more urban counties like Hamilton, Franklin, Cuyahoga, all of their chronic disease rates are lower than these rural areas here. Of course, urban areas have other health disparity issues, but that's a whole different webinar. So looking at the causes here, what were some of the causes behind this health disparity in the story? Well, obviously food deserts for one, that's one that they mentioned right off the bat. Lack of convenient access to healthful foods. There were only prepackaged items available at the local Dollar General. People were driving up to 30 or 40 minutes just to find fresh food. And that relates to another cause, which was geography. This is a rural and auto-oriented area. It doesn't offer many options for walking or biking. And so if you don't have a car, you might not have convenient access to healthy food. Now, the new market is located in downtown MacArthur, and it's connected to the sidewalk network, so that's a big improvement. And then the last one, there are more, but we'll just go over these here. The last one is poverty. As the story mentioned, 20% of the county lives in poverty, and the median income for the county was $10,000 below the state's median income. So when you have a low-income population concentrated in an area like that, that dissuades full-service grocery stores from entering the market. Unfortunately, in this case, the Healthy Food for Ohio initiative was able to provide grants to offset some of that financial risk for the store owner. Now, this is just one example of how a health disparity can manifest and present itself in a particular population. Because Ohio is a largely rural state, as you can see from the map, a lot of communities are facing this type of challenge. But food deserts can also exist in the middle of cities. They're not strictly tied to rural Ohio. If you live in a neighborhood in Columbus or Cleveland that is cut off from the nearest grocery store by a highway or a railroad track or some other obstacle, and the only thing near your house is McDonald's and KFC, then you probably live in a food desert as well. In this case, we might call it a food swamp because there's so many unhealthy options nearby, but the effect can still be the same, an increased rate of chronic disease. So hopefully that makes the concept of health disparities a little more concrete in your heads as we move forward. And now we're going to talk about a related topic, health equity. So according to Healthy People 2020, which is the nation's health objectives for the current decade, health equity is the attainment of the highest level of health for all people. Achieving health equity requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and the elimination of health and healthcare disparities. I like this definition, as you can see, because I think it's really important to focus on those historical and contemporary injustices and recognize how those systems continue to perpetuate health and other inequities. And by that, I mean government programs and policies and societal trends that have encouraged discrimination against minorities and other underserved groups. Jim Crow segregation would be a historic example, which led to a lot of racial disparities in housing and education, employment and health, and many other factors. Mass incarceration and the over-policing of communities of color will be a contemporary example, and we'll talk more about that later as it relates to active transportation. So we can't begin to address these inequities in certain populations if we don't understand how they are exacerbated by discriminatory policy and the legacy of those systems, and how it continues to perpetuate health disparities. For an example, just tying it back to food deserts, let's say that someone's grandmother 70 years ago was confined to a particular neighborhood because she couldn't get a home loan in a different area due to discriminatory lending practices. And let's say that her descendants still live in that neighborhood and now it's a food desert. So her descendants may be suffering from health disparities due in part to their confinement there because of that historical injustice. Hopefully that makes sense. It's important to keep in mind that when we're working to dismantle health and other inequities, we're fighting against decades of public policy and societal trends that have made those inequities possible. That's what this quote is referring to when it says avoidable inequalities. When we talked about the story in Vinton County, we were talking about what might have caused the health disparity there. Determinants of public health is another way to describe those causes. There are two primary types of determinants, social and physical, but there is some overlap between them, especially when it comes to transportation. For example, if children are dissuaded from walking or biking to school because of the threat of gang violence, that would be a social determinant against their access to active transportation. If they're dissuaded from walking to school because they live in a rural area with no sidewalks and they have to cross a major highway to get to school, that would be a physical determinant because their built environment is not conducive to walking or biking. I won't go through this whole list due to lack of time, but there are a lot of examples, and the main takeaway to remember here is the causes of health disparities are also called determinants of public health, and they can take many forms. Now I'm going to pause the presentation here briefly and do a poll. Hopefully this works. So we're going to talk about some examples of social and physical determinants of public health in your community. And just give me one moment while I set up this poll. Okay, hopefully you all can see those choices now. So go ahead and select any of these options that you think are prevalent in your community. These are just a few from the examples from the previous slide. I'll give you a minute just to fill that out. see the results coming in?
Actually, it says results are hidden from attendees, so you might need to share that with everybody.
Okay. Let's see. There we go. How about now?
It says results are shown to everyone.
All right, great. Okay, so I'll give everyone just another minute or two to wrap up. So it looks like economic stability, social and community context, work sites, schools, recreational settings, and transportation are all fairly prevalent determinants of public health in your community. And unfortunately, we can't engage in more of a discussion on that, but just a reflecting question for you all to think about later: what are their causes? Why are those particular determinants so prevalent in your community as opposed to some other determinant? All right, so we'll go ahead and close out of that poll and switch back to the presentation.
While Michael's doing that, just a reminder, if you have questions, please feel free to put them in the conversation panel, lower left-hand side of your screen. Thanks.
Okay. All right, so we're going to move on now and talk about how transportation relates to public health specifically, especially based on which mode of travel you have access to and what your transportation choices and options are. As you can see in the picture, the woman on the bike is getting physical activity. She looks very happy about that. The person in the SUV is not getting physical activity. They may or may not be happy. It's a little hard to tell. But as we'll see, there are drawbacks and a lot of considerations for both options. So for public health purposes, it would be ideal if our communities were as walkable as possible to create as many opportunities for active transportation and physical activity as we can to reduce those rates of chronic disease. Jeff Speck wrote a landmark book called Walkability, and he developed a general theory of walkability, which discusses 4 tenets for a walkable community. So it has to be useful, a useful walk where you can run errands and walk to school and walk to work. It has to be safe, meaning that there is infrastructure that protects pedestrians from motorized traffic, such as sidewalks and crosswalks. And not only should it actually be safe, but it must also feel safe, be perceived as safe by pedestrians. It must be comfortable. The built environment along the roadway is pedestrian scaled and oriented, and you're not walking between an endless expanse of parking lots and a 6-lane road. And it must be interesting. There are things to look at. There are storefronts, public art, other people. There is a street life that is vibrant and engaging and welcoming for pedestrians. So that would be our ideal walking environment. Some communities look like this, but unfortunately, a lot of them don't. And a lot of them are struggling with attaining all 4 of these tenets of walkability. On the other end of the spectrum, some communities look like this. And these are what we would describe as auto-oriented transportation networks that create barriers to walking and biking. As you can see in this shot of the suburb, they do have sidewalks, but I don't see any offices or schools or libraries or other destinations in this shot. So likely people would have to drive when they need to make an errand or go on a trip. Also, there's not a whole lot of connectivity here because all these roads just end right here. So this is the situation that a lot of communities find themselves in when they're trying to retrofit their built environment to make it more walkable and more welcoming to pedestrians. And that's led to a lot of public health issues. Over-reliance on auto-oriented transportation networks and motorized travel has a lot of impacts on health. First off, physical health. It leads to sedentary lifestyles. When we have a drive-through culture like this, of course, we're going to be struggling with things like obesity. 1/3 of American adults are obese, and some of the leading causes of preventable death, like diabetes and heart disease, have been related to obesity. These conditions often affect low-income and communities of color disproportionately, as we heard in the Vinton County story. And we also have impacts on mental health. Psychological well-being is negatively associated with time spent driving. 66% of recent traffic fatalities can be linked to aggressive driving. That's a pretty scary statistic from the National Highway Traffic Safety Administration. I'm sure if you drive to work every day, you probably had an encounter with someone who looks like that. Or maybe you look like that sometimes. And then finally, impacts on environmental health. Car emissions are associated with other chronic disease and health issues like asthma and bronchitis and school absences in children. Again, low-income communities and communities of color are exposed to higher levels of pollution due to their proximity to major roads and highways. And this is where choice of travel mode comes in. If you are biking or walking down a busy road, trying to create a healthy transportation option for yourself, but you have to inhale these types of fumes, that may be a pretty strong deterrent to choosing an active mode of transportation. To put it in public health terms, these trends can be described as a common source epidemic. That is an epidemic where environmental factors are causing health problems across a population. There's not one specific cause or outbreak or instance, it's pervasive. So we'll do another poll real quick, just to see what the audience is choosing in terms of your primary mode of transportation. So give me one moment while I pull up the second poll. All right, so you should be able to see it on your screen. And I'll give you a minute to fill that out. All right, looks like most people have made their choice. So just to give you some context, I'm going to compare this to Ohio and national statistics and see where we lie as an audience today. So in Ohio, 83% of people drive alone compared to 76% in the US. And that compares with our group to 82%. Actually, I'm sorry, I'm not sure if you all can see this other screen. Let me switch back over.
No, we're still seeing the poll.
Okay, sorry about that.
It's all right. I think you're doing a fabulous job for this being the first time you've presented a webinar, Michael.
Thanks, Victoria. Okay, so let me try that one more time. Here we go. Hopefully you all can see that.
Yes, we can see it. Okay,
great. So again, these are the statistics for Ohio in red and for the US in gray. It looks like our group had a little bit higher of a rate of driving alone compared to the Ohio and US. It looked like we biked and took transit a little bit more. As you can see, in Ohio, only 0.3% of people bike to work, pretty similar in the US. And there are not a whole lot of walkers either. And then I think I did see some people that took public transit in our group as well. So some reflection questions for you to think about on your own. What elements of your built environment encourage you to choose this mode? Or do you even have a choice? Is that your only option? And then how does that travel mode specifically affect your health? Does it have positive benefits or negative impacts on your health? So we're going to talk now about health and other inequities in transportation. As I said earlier, health disparities and inequities can manifest in a variety of ways and for many different reasons. So rather than focus just on one particular type of inequity, we're going to look at a number of different examples on the next slides. I'm not going to interpret or explain every single statistic just due to lack of time, but hopefully this should give you an idea of the many ways in which health and other inequities occur in transportation. For those who are interested, I pulled a lot of this data from this report at the intersection of active transportation and equity from the Safe Routes to School National Partnerships. This is an excellent resource if you want to learn more about this topic, and I highly recommend it, especially for these last two, race and income. So we'll start with disparities and inequities by age. And first here, we're talking about seniors. Only 1.2% of seniors use public transportation on a daily basis, despite the fact that a lot of them are unable to drive and have to rely on alternative means of transportation to get around. Again, for seniors, 3/4 of outdoor falls occur on sidewalks, curbs, and streets, and 47% occur while walking. In other words, seniors are facing a higher risk of injury while they're trying to use an active mode of transportation. Looking at our younger generation now, 10 to 20-year-olds comprise the most common age range for bicycle fatalities between 2012 and 2016. In Ohio, on a related note, 80% of bicycle fatalities happen within 2 miles of a school. By gender, only 26% of bicyclists identify as female, despite the fact that, of course, they are half the population. And then looking at the prevalence of street harassment, 65 to 87% of all women have experienced street harassment. You can see the graph on the right here. 57% have experienced verbal harassment, 41 have experienced physically aggressive harassment. And the disparity here is that harassment rates against men are much, much lower. 90% of women report harassment in rural areas, 88% in suburban areas, and 87% in urban areas. So that goes to show that this is prevalent across different types of populations and communities. It's not tied to one type of geography or one demographic. If you want to learn more about this inequity specifically, I would recommend checking out the website stopstreetharassment.com. By race, people of color are more likely to be killed while walking and biking than white people. As you can see on the right here, African Americans and Latinos are twice as likely to be killed while walking than white people. And while biking, African Americans are 30% more likely to be killed. Latinos are 23% more likely to be killed. This is in large part due to either poor or a lack of bicycle and pedestrian infrastructure in those areas. African Americans make up 33% of public transit riders, riding at a rate that is 2.5 times their share of the population. Many people of color and communities of color are what we call transit dependent, meaning that they have no alternative means of transportation, which might explain some of the numbers behind the statistic. A couple more items by race. Bicycle and pedestrian laws are disproportionately enforced against people of color. Criminal activity, blight, police harassment, and racial profiling, and other environmental factors that discourage active transportation are more prevalent in low-income and minority communities. And this is what I was referring to at the beginning when I was talking about those contemporary systems of injustice and discrimination. So here's a pretty well-known example. Hopefully you can read this on the bottom right. This is an infographic showing New York City Police Department stop and frisk policy data. So even though blacks make up 23% of New York's population, they accounted for 53% of stop and frisk cases. Whereas whites, who make up 47% of the population, account for only 13%. And Latinos, who make up 29% of the population, account for 33%. So that's, again, another contemporary example of how systemic racism and racial profiling can directly affect people's transportation choices and experiences. If you know that you're likely to be stopped by police while you're trying to walk or bike to work, you might be inclined to choose another option if you have one available. By income, sidewalks, bike lanes, and traffic calming infrastructure are much more common in high-income areas than in low-income ones. Major arterial roadways and highways are far more concentrated in low-income areas, which creates more dangers for active transportation users, as you can see in the infographics here on the bottom. A few more items by income. A high percentage of public transportation users are low to moderate income. As the pie chart shows, 42% of transit riders earn under $25,000 a year. 3/4 of high-income communities have streetlights compared to only half of low-income communities. And that relates back to that perceived sense of safety that we were talking about, our general theory of walkability, and the environmental factors that influence active transportation users. And then finally, households in low-income areas typically own fewer vehicles, have longer commutes, and higher transportation costs, as you can see here on the right. Low-income households spend 42% of their income on transportation, compared to only 22% for middle-income households. So I know I just threw a lot of statistics and numbers at you, and not all of them are going to stick, but that's okay. The main points to remember here is that our transportation system suffers from severe and systemic inequities, both health and otherwise, that low-income people and people of color are more likely to be walking and bicycling in dangerous conditions, and that transportation is a public health issue and public health is a transportation issue. I know not all the items we just looked at were health-related, but a lot of them were. Part 2, Active Transportation 101. So on that uplifting note, we're going to switch gears a little bit and talk about how active living can help improve community health and hopefully address some of these injustices and disparities that we've been looking at. So first we'll look at active transportation benefits, and I'm just going to focus on the top row here related to health benefits. These are all important as well, but that's not the focus of today's webinar. So increased physical activity can lead to reduced risk of chronic disease and premature death. Active transportation is a proven way to get healthy levels of exercise. For example, almost 1/3 of transit riders get their entire recommended amount of exercise just by walking to and from transit stops. Adults who get around by walking and biking have lower weight and lower blood pressure, and they're also less likely to become diabetic. Decreased reliance on automobiles leads to less daily stress. Being stuck on the traffic, as we mentioned, or stuck on the highway in traffic, as we mentioned, is not a lot of fun. Taking an active form of travel to work or school eliminates the mental stress that can be associated with driving. And then an improved built environment. By that, I mean a robust bicycle and pedestrian infrastructure that connects employment centers and schools to neighborhoods of all incomes and ethnicities and allows everyone to enjoy the benefits of active transportation, can encourage active commuting. So for those of you who might be a little less familiar with active transportation, we're going to approach it using the 5E framework today. That's looking at these 5 different categories that all have a role in active transportation. Most of them are policy and program related, but we're going to start out with looking at engineering, which is, of course, infrastructure related. Typically, the most successful programs and plans use a combination of these approaches. You can't use one or the other in isolation and expect to succeed. And these strategies can be used, and they should be used for all communities, but there are certain considerations when using them in disadvantaged communities when you're trying to remedy health disparities. Again, unfortunately, we don't have a lot of time to explore that today, but we will touch on it briefly. So first, engineering. It's a critical component of a lot of projects, but it cannot be a standalone component. So creating safe and convenient places to walk and ride, bike lanes, sidewalks, high visibility crosswalks, pedestrian hybrid beacons, whatever your favorite type of active transportation infrastructure is, that's what we're talking about when we say engineering. Education, giving people of all ages and abilities the skills and confidence to walk and ride. This is where our Safe Routes to School training comes in. Trying to get kids started getting physical activity every day and making it a lifelong habit early on in their lives. And of course, there's adult education programs as well. Enforcement, partnering with local law enforcement to ensure traffic laws are enforced and initiating community enforcement such as crossing guard programs. Given what we just talked about with racial profiling and police harassment, the second bullet is a major caveat to enforcement. Law enforcement officers must apply traffic laws consistently and equitably to ensure safe roads for all users. Currently, that is not the case in many communities. So when using enforcement as a strategy in low income and especially minority neighborhoods, you must be particularly mindful of that point if you want to be successful. Evaluation and planning, developing and adhering to planning documents to ensure consistent long-range policy and also monitoring and documenting outcomes and trends of those plans. Encouragement, creating a strong active transportation culture that welcomes and celebrates bicycling and walking. This can come in a variety of forms. This is one example, a Walk with a Doc program, where a physician gives a brief talk on a health topic at a community park and then leads a walk with neighborhood residents. This program started in Columbus and it's spread all over the place. Another example would be Walk and Bike to Work Day, which happens to be tomorrow in Columbus. So if we have anyone tuning in from Columbus, I'd highly encourage you to register for a ride or a route on the way to work. All of these routes will converge at City Hall for a Walk and Bike to Work Day celebration tomorrow morning. Now, given today's topic, I'd be remiss not to mention equity as the sixth E, which is not always included, but it's not a standalone component because it impacts all of the other E's, as we've discussed. Those disparities in infrastructure and health and make it imperative that we focus on equity and on addressing areas of greatest need first in our communities. The statistics that we just looked at and all of that data, that's meant to emphasize how important this is to consider equity in all types of planning, including active transportation planning. So we're going to look at a few case studies and best practices now. Using equity for project prioritization. This is a process that uses measurable data to determine which projects from a given plan are feasible and adhere to certain principles. So projects are scored using a set of criteria and then assigned to an implementation phase based on that scoring system. These are a couple examples from plans I've done in the past. This was a Lawrence County bicycle and pedestrian plan in rural southeastern Ohio. I believe the population was 98% white, so we did not use race as an equity factor, but we did look at income, looking at income that was below the county median, and then also looking at zero vehicle households to see if there were areas that were in greater need of active transportation options. So again, as you can see, there were other factors and other criteria considered, such as access and safety and connectivity, but equity is also on the list, and it's really a quantifiable and concrete way to give equity a seat at the table when it comes to selecting projects. Another example is from our Dayton long-range transportation plan, where we looked at a number of factors: income, race, age, and homes in need of repair, looking at vacancy rates. So all of these were considered when selecting projects in Dayton. And just to show you what this looks like when it's mapped out, so we have housing vacancy rates, which is the green layer of census blocks underneath all this other stuff. We also looked at income by census block and race and age, and just selected a few example projects and scored them based on that criteria to see how equity played a role for those projects. The other case study I'll look at is focusing more on active living and an active transportation program. So this is the Columbus Public Health Healthy Places program. It's been so successful because it uses a top-down and a bottom-up approach. The top-down approach is policy-focused. It uses things like health impact assessments, which we'll discuss briefly, rezoning reviews, and other policy tools. But it also uses a bottom-up grassroots approach, like walking and biking tours, community walk audits, safe routes to school trainings. So it's really a comprehensive approach to health promotion and education around active transportation. And it's been recognized nationally by the Safe Routes to School Partnership and the American Public Health Association. So I'm going to speed through this fairly quickly so we have enough time for questions at the end. Part 3, applying the knowledge, tools, and resources. We're not going to get into this too much today, but we have a number of online tools and resources we can use to explore these issues in your own community. And I'll just show you one briefly. This is the US DOT's Transportation and Health Tool, which looks at the metropolitan statistical area and urbanized area levels, looks at different health indicators. So I just pulled up the one for Cleveland here. It looks at a number of different indicators, from mode share, which we looked at earlier, to complete streets policies, housing and transportation, and then a lot of data on road traffic fatalities for different types of modes. So I encourage you to explore these on your own. As Victoria said, we'll be sharing these slides with everyone afterwards, so you can take a look and see what else is of interest to you. The other tool I want to mention briefly is the health impact assessment. These are tools that assess the impact of a proposed policy, plan, program, or project on community health. And they can be used for any type of project or plan. For example, the grocery store in Vinton County. There could have been an HIA conducted for the grocery store and where it was cited and how it would impact community health. Or you could conduct one for a new highway interchange and figure out how that interchange might affect adjacent communities. Part 4, implementation, building relationships. So this is a timeline we developed that shows some action steps you can take to really delve into health and equity and transportation in your community. And again, unfortunately, we don't have time to explore all of this, but just a few highlights here. Continuing education is, of course, a great way to start. Keep taking webinars, do online trainings, research local initiatives in your community. When you feel comfortable with these topics, make contact with your health department or your transportation department and explore areas for collaboration. Professional development, research organizations that you belong to and join their subcommittees or their groups that relate to health and transportation and equity. Become familiar with best practices and case studies, and then take action in your own community. Partner with underserved communities, partner with local government, and start exploring these issues around health and equity. Of course, if you want to sustain this effort, you need to apply for funding, and we get into more detail with that in the in-person training. And then sharing your success. Once you've made progress in your own community, present at conferences and other venues to share what you've done locally. So hopefully the end result will be a sustainable, interdisciplinary, and collaborative commitment to local health and equity issues in transportation. We're almost done here. I just want to touch on one more item, which is communication strategies during implementation. So the first set of strategies we're looking at is between public health and transportation officials. First off, you want to meet them where they are and find common ground with the other side. Many of the options that communities use to encourage active transportation can also improve public health, so there should be a lot of common ground there. Talk in terms they understand. For example, transportation planning is driven by money, so the cost savings and economic benefit of public health improvements should be included in the discussion. And then become an expert they can rely upon. Both transportation and public health are heavily data-driven fields, so use that data to illustrate your points, and that will help legitimize your views and expertise when you're engaging the other side. And then lastly, and most importantly, communication strategies between local government and underserved communities. First off, you want to be wary of tokening. And that means that, in today's world of affirmative action, there's a lot of postcard diversity where we see a perfect blend of race or ethnicities on a university's or business's promotional material, even though the reality may be a lot less diverse. So people of color and other minorities are understandably wary of being co-opted into that type of process just to lend it an air of diversity or fill a diversity quota. So when you approach communities, make sure that your intent is clear and genuine. Be ready to listen to their concerns. Don't come with your own agenda because it definitely won't last. And then finally, forge partnerships, not power trips. Citizen power and citizen control is the ultimate form of public participation. So if you're not willing to release some of that control to your stakeholders and really ask them for help in identifying what they see as problems around health and equity and transportation, then you might not be ready to engage with them yet. You might still have more education and work to do on your end. I'll leave you with a final thought from Tamika Butler, the former executive director of the Los Angeles County Bicycle Coalition and a personal hero of mine in equity issues and active transportation. She says that we want more leaders who are doing this work to be thinking about these conversations. We want more spaces where the folks talking about equity aren't just the women or the people of color. Even if these topics make you uncomfortable, especially if they do, I encourage you to lean into them, work through the discomfort, figure out how you can affect positive change in this area. Regardless of your skin color or your gender identity or whatever other attribute you can think of, these issues affect all of us. So you definitely need to start applying an equity lens to your work regardless of what you do. And I know that may sound like an overwhelming task considering the many responsibilities you probably have already and the many competing priorities you're dealing with. And initially it will be hard. It will be a difficult process. But I think if you are able to make it a habit and really focus in on these issues when you're working on different types of projects and plans, figure out what role they play, hopefully it will become easier for you as you recruit allies and institutionalize these values in your organization. So that's our presentation. Thank you all very much for listening. And we have about 10 minutes left for questions, I think.
Yep. I'm going to go ahead and open the phone lines up for questions. So I'm getting ready to unmute everybody. If you're talking to somebody else right now, you might want to cut that conversation short because we're going to hear you here in just a second. Okay, I've got everybody unmuted. Now I'll go through and unmute each line individually. At least it's showing up on my screen. If you've got your line muted on your end, feel free to go ahead and unmute and ask Michael any questions that you have. There was a request to share the information about where the statistics were derived from, and I'll work with Michael to get that list and make sure that we email it out to everybody.
Yes, and we have a number of materials for the in-person training that we can share as well that has all of that data and other sources that you can explore on your own.
I can't imagine this audience has no questions whatsoever. No? Well, maybe they're just all going to email you, Michael. Or they may just be looking to schedule the full class, too. We have put the link for that in the chat pod as well, and I'll make sure to send it out to everyone in the follow-up email.
Well, I can stay on the line, Victoria, until 11 in case anyone does have any questions if they want to ask afterwards. I can still be here for a little bit, and my email is right here in case you want to follow up.
Okay. Well, thank you, everyone, for joining us today. We appreciate your time. And Michael said he'll stay on for the next 8 minutes if you have questions. So if not, enjoy the rest of your day.
And thanks again for listening. I appreciate it.
I'm going to go ahead and stop the recording now. So in case anyone was shy about asking